name is Andrea Romano. This is the RCAT-SEN assessment. After I'm done scanning the room and providing for privacy for my patient, the assessment will begin. So here is the computer. There are no notes. Over here, I have provided for privacy. The door is closed. The shades are drawn. This again is my supplies, and again, me and the patient are the only ones in the room. So, hi, my name is Andrea Romano. I'm the nurse practitioner student. I will be taking care of you today. Is that okay?
Yeah, that's okay.
And what brings you in today?
Just pain on my side, right here.
Okay, and how long have we had this pain?
Few days.
Few days.
Yeah.
And can you tell me a little bit what the pain feels like? Is it dull or sharp?
It's pretty sharp.
Sharp?
Yeah, it hurts a lot.
And does the pain move anywhere, like towards your back or up or down?
No.
No?
Really right there.
Okay, and on a scale of 0 to 10, 0 being no pain and 10 being the worst pain you've ever felt, what kind of...
I would say a 7.
A 7?
Yeah.
And this is a dull or a sharp pain?
It's pretty sharp.
It's pretty sharp.
Yeah.
Okay, and is it accompanied by any nausea, vomiting, or diarrhea?
No.
No?
Really hurts mostly after I eat.
After you eat. That was going to be my next question. Anything make it worse?
Yeah, I would say eating.
Eating makes it worse.
Yeah.
And so the pain sort of comes and goes?
I would say yeah.
Okay. And have you ever had pain like this before?
No.
No? And do you have any allergies to any medications?
No.
Do you take any medications on a daily basis?
No.
No? And, alright, so the assessment is going to begin. I'm just going to wash my hands really quick. So your vitals were 98.6. Your temperature was 98.6. Your respiration rate is 20. Your heart rate is 76. Your blood pressure is 120 over 72. You are 5'7", 170 pounds, giving you a BMI of 26.6. Okay?
Okay.
I'm going to start with your back or the posterior chest. So if you could just swing your legs this way. Thank you. Alright, so upon inspection, the skin is pink. I don't see any lesions. I don't see any areas of swelling. The patient is relaxed. I can see the chest rise and fall with just a relaxed, regular breathing. The skin is warm, it's dry. And does anything hurt when I touch here?
No.
No. No pain when I palpate. Okay, so I am going to start by listening to the lungs.
Okay.
So if you could breathe in and out quickly every time I move the stethoscope. Okay? So in and out. Again. Okay, and lung sounds are normal. I don't hear any rales, rhonchi, or wheezing. And I'm going to assess for chest excursion. So if you could just breathe in and out again. And it's a normal symmetrical chest excursion as the patient inhales and exhales. Okay, so I'm going to listen for echophony and bronchoscopy. So every time I move the stethoscope, can you say the letter E for me?
E, 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 E.
And the egophony, I do hear a muffled E, and the sound diminishes as we go down. So if that sound was more like an A, I would know that there was maybe some presence of consolidation. So bronchoscopy, you're going to say 99 while I listen to your lungs.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay. So I hear a muffled 99. If it was more coarse, again, that would indicate to me that there was some sort of consolidation. And I want to note that when I am over here, I'm listening to the right middle lobe, and again, no evidence bilaterally of Rales, rhonchi, or wheezing. Long sounds are clear bilaterally. So I'm going to assess for tactile fremitus. So I'm going to put the balls of my hands on your back. And every time I do that, can you say 99?
99, 99, 99, 99.
Okay, and I can feel the tactile fremitus in the upper lobes of the lungs, but when I get down towards the bases, I don't feel the fremitus as much. I'm going to percuss the lung sounds, and I just hear general resonance when I'm percussing the lung sounds, which is a normal finding. I'm going to assess for diaphragmatic excursion. So I'm going to ask the patient to inhale and hold it, and I'm going to percuss to where I hear resonance, and then when the sound changes to a dull sound, then I know that that's where the diaphragm is. Okay, so can you take a deep breath in and hold it? Okay, and I heard the sound. You can exhale. Right here. Okay, and then I'm going to have the patient exhale and hold it to get the excursion. So can you just exhale, blow out everything, and hold? So the sound changes about here. I will mark it with my pen. And we have an excursion of 6 centimeters, which is within normal limits. I'm also going to assess for costovertebral tenderness. Can you tell me if you feel pain when I do this? Any pain?
No.
No. Okay. You can swing around and face forward. Okay, I'm going to expose the patient's chest. Okay, I'm looking, there is a symmetrical chest. I don't see any retractions, any use of accessory muscles when the patient is breathing. Again, I will assess for chest excursion. You take a big deep breath in and out. And there's a symmetrical movement of my hand, so it is a symmetrical chest excursion. Also going to look at the AP to lateral widths. So we have a 1:2 ratio. There's no evidence of barrel chest. Going to listen to the lungs in the front. Can you take deep breaths in quickly as I move the stethoscope? And again, lung sounds are normal, no Rales, no rhonchi. Inspiration is twice as long as, inspiration is longer than expiration. So I'm going to start with the cardiac assessment. So I'm just going to palpate to see if I can feel the pulses in all 5 areas. So this is second intercostal space, right sternal border for the aortic valve. Second intercostal space, left sternal border for the pulmonic, Erb's point in the third intercostal space, tricuspid in the fourth intercostal space, and mitral in the fifth intercostal space. This is a point of maximum impulse. And can you just lean forward for me? And I can feel, and then over this way. I can feel a light tapping of the PMI on my finger, which again is a normal finding. Okay, I'm going to percuss the chest quickly. I should hear a bit of resonance. Okay, and then I'm going to listen for all heart sounds. So again, aortic, Pulmonic, Erb's point, tricuspid, and mitral. I can do this with the bell as well. And then to assess for murmurs, I'm going to have the patient lean forward in the aortic area. Okay, and then lean over that way and forward. Okay, and you can come back up. So I only hear S1, S2 in all 5 of the areas. There are no clicks, there are no gallops. I didn't hear a murmur in the aortic or mitral valve area. So I'm going to have the patient lay down, as we're going to move on to the abdominal assessment. So I'm going to pull this up for you. And again, while he's laying, I don't feel any heaves or thrills. So again, that's a normal finding. So I can see the patient is breathing comfortably. I see no evidence of ascites. The umbilicus is inverted. I don't see any abnormal vascular pattern on the abdomen. I will auscultate before I palpate. So I'm just going to listen to your abdomen in all 4 quadrants. And I can hear the gurgles and clicks of the abdomen. So I'm just going to move through this quickly. Bowel sounds are normal active. If I thought they were hypoactive, I would listen for longer. I'm also going to listen for vascular sounds. So I'm listening for the aortic artery. And I could do this with the bell as well. And the left and right renal arteries. And I'm not hearing any bruits in any 3 of those quadrants. So I am going to percuss the abdomen. There'll be 2 different sounds. There'll be resonance and dullness. Resonance is kind of where where there is anything, where there isn't anything, and then if I get a dull sound, I know that I'm over an organ or over a stool. And then palpate over the bladder. Okay, and then I can hear the sounds change as I move around the abdomen. So I'm going to see if there's any aortic enlargement. So I can feel the light pulsation, and I can feel it over here on the left. So there's no evidence of any sort of aortic enlargement. I am going to do palpation in all 4 quadrants. So I'm going to start with light. Can you tell me if there's any pain? Any pain?
Yes.
Here?
No.
No? Here?
No.
And then I'm going to do deep palpation. Any pain?
Yeah.
Pain?
Yeah.
Okay. Pain here?
No.
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 Okay.
No.
I'm going to assess for rebound tenderness. So I'm not going to start generally over where the appendix would be. So I'm going to start a little bit lateral of the belly button on the right side. Is there any pain?
No.
Any pain?
No.
Any pain?
No.
No. Okay, good. All right, so there's no costovertebral tenderness. I'm going to assess for the psoas. Can you lift your the psoas sign? Can you lift your leg that I'm touching? Is there any pain?
No.
No? Okay, you put your leg down. And then we're going to do the obturator sign. And this is to assess if we have appendicitis. Did that hurt when I did that?
No.
No? Okay, so there's no evidence of rebound tenderness, and psoas and obturator signs are negative. So we're going to continue with palpation. I'm going to, actually I'm going to percuss for the spleen. I don't hear any sounds that would indicate to me splenomegaly. We're going to percuss for the liver. Again, I don't hear any sounds that would indicate that the liver had extended past underneath the rib cage, but we're also going to palpate for that as well. I'm also going to percuss the gastric bubble, and again, I just hear that tympany, and resonant sound, which indicates that I'm over in a pocket of air. So I'm going to start by the belly button, because if the spleen is going to enlarge, it's going to come down here, and then I'm just going to feel around the left costal border. And I don't feel any evidence of splenomegaly. So I'm also now going to assess for the liver. So come over here, take a deep breath in, okay, and out. Alright, and I can just feel the tip of the liver, but it's mostly tucked right underneath the rib cage, so again, that's a normal finding, negative for splenomegaly or hepatomegaly. I am going to measure for the liver border. So, again, I'm going to percuss down until I hear a dull sound, and then it has changed to a dull sound here, and then I will continue percussing until I get a more resonant sound. Okay, and then I'm about here for where the liver ends. And we are at 6 centimeters, which again is within normal limits. Going to assess the inguinal lymph nodes. Obviously, if we were doing an examination, the pants would be off, but for the modesty of the patient, I will be going over the pants. Okay, and I don't feel any lymph node swelling. You can sit back up. Going to assess the musculoskeletal and sensory of the patient. So, can you tell me your name?
Tony.
And when's your birthday?
May 4th, 1983.
Okay, and approximately what time of day is it right now?
It's the evening.
Evening time?
Mm.
Okay, and where are we?
We're in our house, our own house that we live in.
Okay, and who's the president?
Who should be the president? Who's the president?
Who's the president?
Joe Biden.
Joe Biden. Okay, so patient is oriented to person, place, and time. And so I'm going to assess abstract reasoning. So, can you tell me how an apple and an orange are the same?
Same shape.
Okay, and how are apple and orange different?
One's citrus, one's a fruit, one's I don't know. One's orange, one's red.
Okay, and so abstract reasoning is intact. And I'm going to assess your judgment. So,
Okay.
If you wanted to get to Florida tonight,
Mm-hmm.
How would you get there?
Fastest way would
The
be
fastest
plane.
a plane. Okay. So judgment is intact. I'm also going to do the NIH stroke scale. Can you tell me what's wrong in this picture?
Kid standing on a chair, trying to get cookies at the cookie jar,
And
he's falling. Well, I think the chair looks like it's leaning over.
okay, and then in this picture, what's wrong with this picture?
The water's running over the sink onto the floor.
So that's good. All right, and then if you could close your eyes and give me your hand. I'm gonna ask, keep your eyes closed. I'm gonna put something in your hand. You tell me what it is. You can feel it.
Oh, I can feel it. Okay. It's like a key.
It's a key. Okay. And then I'm gonna write something in your hand. You tell me what I wrote.
An 8.
An 8. I did. Okay. So cognitive and neurological function at this point is intact. You can open your eyes.
Okay.
So again, I'm going to be looking at the joints of the hand. So I don't see any nodules, any swelling, I don't feel any crepitus, patient is not reporting any pain when I palpate. So can we flex our hands, extend them? Can we adduct our fingers, kind of give a little roll? And then can we, yes, touch each finger with your thumb, hand over hand. Perfect, thank you. And then can you push up? Okay, and down. And grab my fingers, squeeze. Okay, so a +5 strength in the hands, which again is a normal finding. And again, I will look at the forearm. Can we bring our hands into ourselves, out? Okay, and push up, and down, and out, and in. Okay, again, 5+ strength in the lower arm. We're going to move up to the elbow and shoulder. I don't see any swelling of any of the joints. Again, I don't feel any crepitus. Patient is not reporting any pain with palpation. I will be doing the rest of this examination unilaterally for the sake of saving time. So can we flex our arms up and then extend them, hyperextend them, abduct, adduct. Okay, and range of motion is intact. Again, arms out. Okay, push towards me. Okay, so strength is +5 in both extremities. I'll be moving on. You can lay down. We're moving on to the legs. Okay, can you bring your toes in towards you? Any pain when we do that?
No.
Okay, so we have a negative Holman sign. You can point your fingers, your toes forward, move your toes in and out. Okay, and hear a little light cracking on there, but the patient is not reporting any pain. I don't feel any swelling. There is no pitting edema. And then can you close your eyes? Can you tell me what position your toe is pointing?
Down. Up.
Same thing with your fingers?
Up. Down.
Okay, positional response is intact. Okay, so we're looking at the knee. I don't see any swelling. Patient's not reporting any pain with me palpating it, so we're just going to move the knee. Okay, and so can we push up, down, towards me, in? So we have +5 strength in the lower leg. We'll move up to the hip. Patient is not reporting any pain. So can we lift up? Okay, down, out, in. Good job. All right, so we're going to assess the peripheral vascular. So I'm going to have the patient lift their leg, and I want so the blood's going to drain from the leg. I'm going to notice the color change. Can you move your wrist around? Your ankle around? There we go. So the foot changes color as the blood leaves it. Now can you just sit up quickly and hang your leg over the table? Okay, and I can see that the leg quickly fills with color in less than 10 seconds. So again, that's a normal finding for our peripheral vascular system. Okay, I'm going to perform the Allen's test. So I'm going to occlude the radial and ulnar artery. Can you make a fist? Now release the fist. And I can note the color change. And then I'm going to release the ulnar artery. And the hand returns back to pink, which is good collateral blood flow. So again, can you close your fist? And then open it. And then I let go. And the hand quickly returns to its normal color. So again, patient has good collateral blood flow in his extremities. Okay, so I'm going to assess for carpal tunnel. Can you press your hands like this together? Really, really hard. And do you feel any pain, numbness, tingling?
No.
No? Okay. And then I'm going to, again, this is another test for carpal tunnel. Let me know if you feel any pain, numbness, or tingling when I hit you over here.
No.
No. Okay, so patient negative for carpal tunnel. Going to get some other supplies. Okay, so I'm just gonna feel for pulses right now. So radial pulses are even bilaterally, they are 2 plus, and brachial pulses 2 plus, symmetrically bilateral. Okay, I'm gonna do unilateral popliteal. Okay, popliteal is 1 plus. I have the pedal pulses 2 plus, posterior tibial is a 2 plus. And again, I would be doing this bilaterally, but for the sake of this examination, we're only going to do it unilaterally. I'm going to assess for reflexes. So this is the radial reflex, and I'm going to be looking for muscle twitching in this area. So I can see when I hit that tendon, we do have a brisk 2 plus reflex. And we're going to do the brachial to see if the bicep contracts, and I can see the light contraction of the bicep muscle. And then we'll do the popliteal to test for the tricep. And again, I can see that quick, brisk 2 plus contraction of the muscle when I hit it. We're gonna do the Achilles. So I'm just gonna hold your foot, and I can see the contraction of the foot. And then the Babinski. This is a negative Babinski. It was positive the patient's toes would curl forward. Can you pull your hands apart like this? And the patellar reflexes are 2 plus, brisk, and symmetrical on both sides. You can stop doing that. It was just to distract you so that you didn't pay attention to the reflex. Okay, so I'm going to ask that you close your eyes, and I'm going to touch you with soft and a sharp object, and you're going to tell me where and whether it's soft or sharp. And we're doing this on your upper and lower extremities.
On my arm. Soft. Sharp. Left arm. Right arm. Soft. Left arm. Sharp. Left finger. Ring finger on my right hand. Sharp. Soft. My right eye. Soft on my left calf. Sharp on my right foot.
I'm also going to ask you to remember 3 words. Apple, table, chair.
Okay. Apple,
Okay.
table, chair.
And I will ask you about those in another couple of minutes. I'll do another test for sensory. You can open up your eyes. And I'm going to take this tuning fork and I'm going to put it on some bony prominences. And you're just going to tell me what sensation you feel.
It's like a buzz.
Like vibration?
Yeah. Yeah. Vibration. Yep. Vibrating.
Okay. And again, I would be doing this to assess if the sensation was equal on both sides. But for the sake of this examination, we are only doing it unilaterally. Vibration?
Yep. Vibration. Yep.
Okay, so the sensory is intact. Okay, I'm going to ask you to stand up. You can come around this way. And I'm going to look for any varicosities in the legs. I do not see any varicosities in the legs. I'm going to assess the spine for scoliosis. I also like to start with putting my hands on the patient's hips and kind of seeing where my hands line up. And right now my thumbs are even with each other. Can you bend over at the waist and try to touch your toes as far as you can go? Okay. So I don't see any curvature of the spine. I don't see any evidence of, you can come back up, I don't see any evidence of lordosis, kyphosis, or scoliosis. So I'm going to assess your gait right now. So if we could stand over here. And if you could just walk towards me. Alright, gait is steady, arms swing in opposition. Can you turn around and walk on your tippy toes? Patient's balance is intact. Okay, you can stop. Come back and you walk on your heels. Again, balance is intact, patient's gait is steady, and then walk heel to toe. No, heel to toe, like one in front of the other.
Oh, okay.
And I see no issues with the patient's balance or gait. You come stand over here, feet together. And we're going to assess cerebellar function. Patient is not waving. Again, we would do this for 30 to 60 seconds, but for the sake of this video, we're just going to do this quickly. Can you close your eyes? And I don't see any evidence. This is a negative Romberg test. Patient is not swaying or losing their balance when they close their eyes. Okay, you can open up your eyes again. Can you tell me those 3 words that I told you before?
Table, apple. I don't remember. Table, apple, chair? I don't know, is it?
Okay. And we can take a seat. All right, and I think that concludes our assessment for today. So again, thank you very much for watching and have a wonderful day.